It is my distinct pleasure to welcome you all to the 2025 Annual Conference of the Center for Competition Policy, which is often known as the CCP. My name is Sean Ennis, and I'm the Center Director and Professor of Competition Policy at the Norwich Business School of the University of East Anglia. As the British statesman Winston Churchill once remarked, difficulties mastered are opportunities won. In these challenging times for the university sector, the Center for Competition Policy has not only mastered difficulties, but has transformed them into opportunities, fostering groundbreaking research and expanding our global reach. Indeed, as a center based at the University of East Anglia, we understand the broader financial challenges facing the university sector. However, the CCP itself has consistently delivered a positive or neutral financial position for 5 consecutive years, ensuring our self-sustainability and reliance on our own funding sources. This fortitude allows us to continue our ambitious research goals and make impacts around the world. The Center for Competition Policy, rooted in the University of East Anglia, has a long and proud tradition of excellence in competition, economic regulation, and consumer policy. We represent multiple disciplines: economics, law, business, politics, but we have common topics of interest. Our strength lies in our vibrant, multidisciplinary community, comprising approximately 25 faculty members, a growing number of affiliate members, and invaluable partnerships with key UK government bodies, most of which are represented here today, as well as key sponsors. This year's conference is titled Frontiers in Competition and Regulation, and it's a testament to our ongoing commitment to frontier research, joining academic and policy interests. Looking back at the past year, it was really a year of exceptional productivity and significant successes for CCP, so I hope you will indulge me as I walk through some of those. Our projects and activities have really been diverse and impactful. In collaboration with a consortium led by ECA Economics and Lear, we were awarded projects from the European Commission's DG Competition. These included exploring the state of competition in the EU across selected case studies like aviation, telecom, beer, groceries, mortgages, and cement, and collecting merger data from EC merger decisions since 2002. Those are 2 different projects. This latter project is set to conclude very shortly. We've made some of what we hope are final contributions to that in the last days. A particularly exciting development for the center is the Horizon-funded research award on artificial intelligence for AI policy, which we call AI for Pol. This project, in which CCP members Jens Prüfer, Sean Ennis, Amelia Fletcher, Raphael Marcolis are involved, so I'm involved, are focusing on the regulation of trustworthy and ethical AI in financial products for consumers. And that includes areas like robo-advice, as well as other financial service topics. AI for Paul brings together researchers from technology development, ethics, law, economics, and political science with partners including Tilburg University, which is the lead university on the project, and Technical University of Munich. It's a more than €3 million project over 3 years and is really quite a substantial effort. We were fortunate to be one of the 3 winners out of more than 40 bids in that particular tender. So crucially, this work has started up already and will be running for years forwards. And I'd like to encourage anyone who wants to talk to me about these topics to not hesitate to step forwards and later, and we'll have a discussion. Another project involves Sally Broughton-Makova with Yuan Gao and others, and it secured a significant bid over 36 months looking at the Digital Service Act, and I don't really know all the details of what they're doing because they're confidential. So, but I think it's very interesting. I'm sure it's very important and interesting what they're doing, because the submission that they made was talking about systemic risk in these areas, and that's one of their topics, I think. We have a research project with the UK Energy Research Council, which is part of the UKRI-funded institutions, and that was on distributional effects of gas price volatility, concluded successfully in September of last year with a report and a webinar presentation of results, and really has some great research papers that have come out of that. We launched a regulatory sandbox. So this you might think of as impact work with the Greek power distribution company Hedno, which was organized especially with the initiative of Raphael Markalos Apostolos Cordis, and I've been involved there too. This sandbox design is intended to help meet new energy needs and support the green transition by allowing the distributor to adapt its own standards and evolve custom tests with companies. Our annual research forum was attended by 25 members and delved into future areas of research. We have an IO summer school, last one held in June 2024, next one next week. And that's still possible to take part in that. And we have had presentations at those at the summer school by Farasat Bokhari, Jens Prüfer, Inga Grafe, Kayove Kuhn, Franco Mariuzzo, and myself. We engaged in a small project with the University of Johannesburg and the South African Competition Commission that involved Franco Mariuzzo. We have also hosted the annual Competition Policy for Economists course, organized by Amelia Fletcher and very kindly hosted by Clifford Chance here in London in October last year, and another one is coming up this year. And then we ran the third UK Digital Economics Workshop in November 2024. Apologies for all these details, but I really want to give you a sense of what goes on at the CCP, and there's a lot. Our partnerships remain crucial. Clifford Chance continues to be a fantastic sponsor, supporting our research and specialized events. We co-organized a successful panel discussion on competition in the food supply chain in Washington, D.C. in April this year, which was reported to be highly successful. And we're really keen to organize more such events in locations around Europe, for example, as well. And this sponsorship has always recognized the full independence of CCP research, but also provides at the same time an excellent outlet for disseminating our work and suggesting timely topics such as cloud portability and interoperability as a topic, which certainly has been an interesting one over the last years. They also provide a student prize for the best antitrust student at the law school, which has led to trainee job opportunities for our law students. Our core subscriber organizations include the CMA, Ofcom, FCA, FRC, and the Payment Systems Regulator, and they continue to engage actively with our workshops, and we're looking forward to organizing several of those in the fall. We've welcomed external visitors, including Przemysław Ostoszki from the Warsaw Justice Academy. And we've seen how hosting visitors can lead to good spillovers. For example, in 2023, we were honored to have a visitor from the Japanese Fair Trade Commission, Mr. Nakata, who stayed with us, and since returning to Japan, a sizable cohort of officials from their organization have registered for various of our programs. We have a blended format seminar series, which is continuing to be highly popular, allows us and the speakers, we hope, to mutually benefit from sharing research. And we're increasingly opening these seminars to a wide set of visitors, sometimes completely public. And so to find out about them, please do be sure to sign up for CCP updates on the web, and then I think you'll learn about these seminars as they're being planned. Our postgraduate certificate on competition and regulatory policy has truly become a vital pillar of our activities for the center. This is an online part-time course designed for working professionals in the competition and regulated industries. And it continues to attract students not only from the UK and the UK regulators, but also globally, from New Zealand to Mexico, Canada to South Africa, Trinidad to Malaysia. We've had students That's the great thing about this course is that people can participate from wherever they are. And we've seen repeat business on it from the UK regulatory sector, especially the CMA and FCA, as well as some of the other regulators. This course is a key strategy for us to transfer knowledge, to have leading edge researchers discussing topics of relevance for regulators with regulators who don't always have specific specialized training that they will have been able to go through in their own university career or as they arrived at the regulator. And so this certificate has been a real interesting project for us. It includes 9 mini modules that cover essential aspects of competition and regulatory policy. And you can find out more about that at our website. In final points, in 2024, our faculty members were prolific. They produced really an impressive 33 journal articles, 2 books, 5 book chapters, and a lot of working papers and reports. Furthermore, we provided consultation responses, which is relatively rare for research centers, and we've now, over our lifetime, provided more than 100 consultation responses, which I think is a really valuable extra activity. It's not one for which university researchers receive any special credit, but I think it's one that we all value and have devoted a lot of effort to making that happen. So some news about our colleagues. It is with a heavy heart that I note the sad passing away of our younger and active member, Jan Siragulwana, in the last month. Jan was a valued part of our community, and his contributions will be deeply missed. We also acknowledge that this year, Morten Havid, a former director of the Center for Competition Policy, my predecessor, will be retiring formally. And so we wish him all the very best for that and thank him for his significant contributions. And I'm very confident that he's actually going to remain active in the future with CCP, so I look forward to that very much. Despite the broader financial challenges faced by the university sector in the UK, the CCP has managed to demonstrate financial resilience, and I have to acknowledge the efforts of all of our members and our staff for making sure that could happen. It's been absolutely crucial, the efforts that they have put in, and I want to make sure they're well thanked for all of those efforts. And I hope that with some of our long-term projects that we've got for the next few years, we will also be able to maintain this type of funding neutrality, which is a great achievement for a research center. We have continued to strengthen our interdisciplinary research ties and providing various sorts of services to our members to support them in the REF cycles. So the last REF cycle involved a lot of work from us, and the next one will as well, and we really hope to find some interesting ways to support our members in that work. This conference, held here at Clifford Chance's auditorium in Canary Wharf, reflects our strategic move to be closer to policy and practitioner communities, enhancing attendance and links. We're really excited about the opportunities this type of conference brings to further our mission and ensure that research has a real-world impact. And just for everyone here, I would like you to recognize and realize that actually the number of people attending this conference is many times more than that we have in the room, because the online attendance will be double or triple the in-person attendance. So keep that in mind. If you think you're speaking to a small group, it might actually be a larger group than you had anticipated. For those who are joining virtually, please do feel free to spread the word as you're watching. If you think his sessions might be interesting to your colleagues, it's possible to sign up very fast and get into these sessions. So we would welcome you. And I guess it's time for me really to thank you all for being here today. Those of you who are in person get a special thanks and some food occasionally, and coffee, but those online as well. Really, thank you very much for coming. And together, we're going to push the frontiers of competition and regulation today and tomorrow, and more generally, turn difficulties into opportunities, as Winston Churchill wisely suggested. So now, without further ado, I want to pass you over to this conference's co-organizer, my partner in crime, if you will, Farasat Bokhari, who's a professor from Loughborough University and a dedicated and active member within the CCP. Thank you.
Good morning, everyone. I'm Farasat Bokhari, Professor of Economics at Loughborough University and an affiliate of the Center for Competition Policy. I'm delighted to be co-organizing this year's CCP annual conference titled Frontiers in Competition and Regulation. Following on from Sean's welcome remarks, let me take a few minutes to introduce the structure and scope over the next 2 days. As always, the theme and sessions reflect CCP's mission to engage with the most pressing, and policy-relevant questions in competition and regulation. This year's program brings together a rich and timely mix of topics, from digital markets and AI to healthcare, pharmaceuticals, financial services, and energy. Across all these, we see an increasing political and legal attention on how competition policy interacts with broader public goals, including innovation, access, consumer protection, and fairness. We're pleased to feature a diverse group of presenters, from PhD students and early career researchers to senior academics and practitioners. The mix brings perspective and deep expertise and reflects the collaborative, multidisciplinary spirit that CCP fosters. Today's program begins with a strong focus on healthcare and regulated markets, including work on hospital performance and pharmaceutical competition. We'll hear about hospital market power, CEO performance in NHS hospitals, and pricing behavior in essential services, followed by sessions on exclusivity, advertising, acquisitions in pharma, along with assessments of recent antitrust cases. Importantly, we also include a session on regulating prices, profits, and firm behavior in sectors like utilities and soft drinks, broadening the lens to core questions of competition and regulation. A policy session on healthcare pricing follows, and the day concludes with more research on pharma markets and merger strategies. We're also fortunate to hear a keynote from Marty Gaynor, speaking on the role of economics in competition policy, a timely and foundational topic. Tomorrow, we turn to mergers, remedies, and digital regulation, with sessions on the innovation effects of mergers, experimental merger review, and emerging rules for digital ecosystems. Our policy sessions on AI and financial services and the boundaries of digital regulation, highly topical and forward-looking. The day closes with work on UK's new DMCC legislation. We're also delighted to welcome Jenny Haddock for our second keynote, a view from CMA, and to host lunchtime remarks from Frederick Jenny, who will reflect on antitrust and competition law at a crossroad over here. Across both days, our aim is to connect academic insight with real-world relevance and policy impact. Thank you to all the presenters, chairs, and all of you for being here. We look forward to a lively and constructive event. So let's get started. Thank you. Back to you, Paul.
Okay. So we will now make the transition immediately to session one, for which I'm going to be inviting Carol Proper to take the floor. She is at Imperial College London and Monash University, and a full bio is in the brochure, which I'd invite everyone to refer to. We're not going to be introducing people with long introductions, so please, Carol, come up and take your seat, well, I guess stand, to talk about the role of top managers in the public sector, evidence from the English NHS. We look forward very much to your launching presentation for this conference.
Thank you very much, and thank you very much to the organizers for inviting me. It's a pleasure to be here and an honor. I'm going to be talking about something that many of you probably have kind of vaguely wondered about, but may not have kind of researched in any detail. And this is a research paper that I'm presenting the results from and the broad overview of. So please do interrupt me as I go along, if you wish. I don't have any objection to people kind of waving their hands and saying, that doesn't make sense, or kind of, can you repeat what you said? So this paper is, as it says, the role of top managers in the public sector, evidence from the English NHS, which I've worked on for most of my academic life. And it's joint with Katerina Janke, who's at Lancaster, and Rafaela Sadun, who's at Harvard. So the kind of motivation behind this paper is that from the 1980s onwards, a very popular reform model for public services was to move from essentially centralized bureaucracies to more specialized and autonomous organizations. And this model involved greater coordination by market mechanisms and contractual relationships rather than hierarchies of bureaucratic authority. It was popular across the world. It was popular, the World Bank and the IMF, both, but particularly the bank, particularly embraced this model to try and increase the productivity generally of public services that were seen as unaccountable, bureaucratic and slow. The emphasis in this model was on the role of managers, and in bigger organizations, senior managers, giving those managers greater autonomy, and then holding them accountable rather than through bureaucratic control, holding them accountable through a series of kind of more market type instruments like manager-specific compensation, performance-related pay, and then tighter monitoring and dismissal for failure. So the idea was to kind of, in a sense, tighten up what was seen as a rather kind of loose bureaucratic control. And the question that, as I say, this model was introduced across the world. It was very popular in education, from places from like Chile to Pakistan. And it was popular in organizations like, for example, social security offices. But it was also used in larger public organizations, particularly in the British state, which was one of the kind of leaders in this field. And this paper asks, does this model of essentially mimicking a private sector organization and its structure and its governance arrangements within the public sector in a large public organization, does it work? Now, we are not evaluating a reform, we are evaluating something that was introduced some time before the period we look at. So essentially we're asking the question that from observed data, observational data, can we infer something about performance of this organization within this kind of arrangement? So what we're going to do is examine the impact of senior managers, and by that I mean the board, and I'll give you a few more details, on performance in a context that essentially completely epitomizes this shift from a traditional bureaucratic organization with heavy central control to a more accountable and autonomous entity that still operates wholly within the public sector. And that's the English NHS, and specifically we're looking at hospitals in the English NHS. What we're going to do is, technically, we're going to evaluate whether differences in organizational performance can be attributed to members of that senior management team. And I'm going to use the term senior managers, senior directors, as synonymous with individuals on the board, executive directors on the board. We're going to focus on a set of key measures of hospital production. And we're also going to be able, unusually in this literature, to also look at their pay. And the question what we're going to do technically is we're going to exploit the fact that these senior managers rotate between these hospitals, not in a defined kind of government-led rotation, but they tend to move between hospitals for different jobs, and we're going to ask whether that allows us to isolate the differences in individual performance from the differences in across the hospitals that they manage, and other time-varying factors. And then the second question we're going to ask is, okay, we're going to look at performance and see whether performance can be attributed to individual board members. And secondly, we're then going to ask if it can, or even if it can't, whether there's a variation in top director pay, and whether that pay is associated with individual contributions to hospital performance. So that's kind of that broad outline of where I'm going. In terms of the broad outline of what we find, interestingly, we find minimal performance impact. Senior managers, including the CEOs of these organizations, only account for a small proportion of the variability or the variance in hospital performance. Most of the performance differences are attributed to hospital-specific factors rather than individual management. You may say, okay, hospitals are very big organizations. We expect quite a lot of the variability in hospitals to be actually attributed to the kind of key features of those hospitals, which may be time invariant. But so we also look to see whether a manager who performs well in one organization can take that performance to another organization of a similar kind. And we actually find that there are non-portable managerial impact. What I mean by that is managerial effects are generally not consistent across moves, i.e. they're not transferable when a director moves from one hospital to another. And then finally, in terms of the pay-performance link, we find there is significant pay variation, suggesting that the market sees these directors as different, some of them better than others, significantly statistically better than others in that they pay them statistically more. But those pay variations are not attributed with are not correlated with their performance in hospitals, either their performance in a hospital or their performance across the whole period in which we observe them. So that's kind of where I'm going, and that's kind of the bottom line of what we find. So in terms of, as I say, this is a kind of précis of an academic paper, so I'm going to present it in an academic way. I'm going to first tell you about the reforms, for those of you that don't know, the data that we use briefly, the methods that we use to do this, and then I'm going to present the results and discuss possible reasons for those results. Then I'm going to shift to looking at whether pay for performance exists and conclusions. So as a kind of backdrop to this, this model was believed to be a good model to basically import into the NHS, and follows a series of corporate governance arrangements that were made in the British private sector and then mimicked in the British public sector. I mean, obviously, there were other things that were going on in the public sector when this model was adopted, including the large-scale privatizations of utilities. This is not privatization, but this is a belief that the discipline of a kind of quasi-market will improve performance. So, in terms of the reforms, NHS hospitals are large organizations. They have around, at the period we study, which is 14 years from 2000 to 2015, they have around 4,500 employees. They treated then about 75,000 patients per year. They have multi-million pound turnover. These are large organizations and complex organizations in that they do a range of activities. So from the late 1980s, this a traditional, very bureaucratic, partly run at regional level approach was replaced by this move towards a highly decentralized model that mimicked the private sector governance models. So that model had several components to it. One was a belief in corporate governance. There was a Boards were created with executives and non-executive directors. Those boards were responsible for the performance of their hospital, responsible to the central state, rather than directly responsible. So that, in a sense, if you think about it, the regulator is the Department of Health. Then there were market mechanisms for paying these hospitals, moving from a system in which hospitals simply got budgets based on last year's activity, plus or minus a little bit. Budgets were financial arrangements were such that about 60% of activity was paid for on a basis of essentially money following the patient. So you move from a kind of certain budget stream to an uncertain budget stream within year. There was stress on the role of the top directors, that top directors were responsible for the performance of their organization. They could be named and shamed if they didn't perform, or indeed fired. And there's some nice work by John Forder and his colleagues that show that directors who don't perform well are more likely to be fired during this period. Director selection was done in exactly the same way that director selection is done in the private sector, using search companies. And director remuneration was set by the board with a remuneration committee, as in a private sector organization. So you can see that the whole idea was essentially to mimic corporate governance, partly given that governance stresses that accountability and managerial performance are important in it. So kind of what data do we use to evaluate this? So we collected data on all NHS short-term hospitals. That basically means not hospitals specializing in mental health care, and not hospitals that are small in the community, for example, for things like rehab. These are essentially what you think of when you go to a large NHS hospital. There's about 200 of them at the time we're studying them. We collected this over a period, as I say, of 15 years, 2000 to 2014. And then we matched this to administrative data on performance of those hospitals, on staffing of those hospitals, and data on director pay. We actually have about 30 indicators of inputs and throughputs and some measures of clinical performance. So what we're going to do is we're going to focus on a subset of those, and I'll get to that. So telling you a little bit about the board composition. The board composition had a kind of key executive positions of a CEO, a medical director, this business is hospitals, a nursing director, nurses account for about 50% of the staff in a hospital, the finance director, the HR director, and as the period goes on, a number of other directors, for example, directors of quality or directors of information. The average board size in the period we look at is about 6. Now, in order to kind of isolate the impact of an individual from the hospital they're in, you need people to move across hospitals, technically. Otherwise, you can't isolate the differences. And in fact, there's considerable movement in these hospitals. Between about 50 and 80% of the hospitals experience a change in at least one member of the board. And that's similar for actually the CEOs. So a lot of the literature in this area has studied private firms and studied just CEOs. Not many people study the performance of the board in the way that we have in this paper. And about, as I say, 12 to 25% of hospitals have a change in CEO. So average tenure is short. Average tenure is about 4 years of these folk. And then they tend to move to another hospital. Some of them move out to the private sector, but the private sector, there isn't a big private sector hospital sector, particularly in the period we're looking at. They tend to move into being consultants to the NHS or the Department of Health, and move often back in again to another director role. So what production measures do we look at? As I say, we've got about 30, and in fact, we have the same results for a range of things like the number of nurses hired, the number of doctors hired, capital inputs, other things like that. We actually, in this paper, focus on a subset of highly political salient performance measures that the Department of Health, as the regulator, cared about. And what we look at is, first of all, surplus. These are publicly funded organizations. Not running a deficit is one of the aims. They haven't got any kind of profit, but they are able to make surpluses, which that they can then reinvest the next year. We look at waiting times. Waiting times are an extremely important indicator of any healthcare performance where healthcare is allocated free at the point of delivery. I don't have to tell people in Britain about that. We look at the number of day cases because that's a measure of kind of efficiency. Length of stay, similarly, you want to bring lengths of stay down because long lengths of stay are extremely costly to a hospital, both in terms of just having patients sitting in the bed, but also blocking someone else moving into a bed. We look at an infection rate as a sole measure here of clinical outcomes. And then we finally look at staff satisfaction, because obviously these are 70% staff organizations. Staff satisfaction, although not targeted by the government, all the other measures were targeted by the government as a key metric at some point. Staff satisfaction was not, but we view it as important. So the methods, I'm not going to spend a lot of time on the methods, but for those of you kind of who are academics in the audience and know about this, what we're using is what's called a two-way fixed effects model, established by also known as an AKM model, which isolates the importance of directors in performance and indeed in pay. We use the same model from aspects of hospital production. So essentially what this model allows us to extract is a long-term fixed effect for the hospital, i.e. a kind of long-term, over the 14 years view of how the hospital performs, separately from a long-term view of how the directors perform in all our performance measures. And essentially mobility between hospitals allows us to, as I say, isolate the impact of directors from the hospitals they're in. Obviously, if you're always in the same place, you can't tell whether bad performance is due to the organization you work for or to you. We do exactly the same for director pay. So there we're asking some hospitals will pay more than others. We're trying to isolate again and some directors will be paid more than others. Can we isolate the impact of director pay from, say, that some directors will work in better paid hospitals, some directors will work in less well paid hospitals. So exactly the same thing. There are technical measures for making sure that essentially what you're estimating is a causal relationship. I won't go into them, but essentially we have a very large data set. In this game, often people look at relatively small organizations which do not have large data, and there's worry that you don't have enough mobility to isolate the impact of directors. We have about 8,000 people across 2,000 hospitals, and we do a whole pile of identification tests. It is possible in these models for good people, long-term good people, to go to long-term good hospitals. That's not a problem. What's a problem is if you have serious match effects. So, for example, if an individual works out well at one hospital, and that's a kind of particular to that match, just as some marriages are good and some marriages are bad. Those are match effects. And then finally we ask, okay, maybe over a lifetime people don't perform that well. What about being able to kind of move from what happens if I performed well at a hospital spell, so whilst I was there, can I take the same activity to another hospital? This is, for those of you who kind of care about the technical details, a decomposition of the variance. And I don't know whether the pointer works. No, because it's a TV screen, but I don't have a pointer. Essentially, the thing to take away from this, and looking at tables is kind of a boring activity, essentially most of the variance comes in the third column from hospitals. There's relatively little variation that comes from the directors. So for example, I've shown you 3 of the outcome measures here: surplus, waiting times, and day cases. And for example, for surplus, only 7% of the variance is accounted for by the board members. For waiting times, it's about 6. And for day cases, which is something you think the directors ought to be able to kind of influence, it's only just over 1% of the variation is actually driven by directors. Most of it's driven by time-varying factors. And you get a similar thing across length of stay, CEOs, length of stay, the MRSA rate, and job satisfaction. So essentially, that 4th column explains very little of the variation. So there's not much long-term difference in the performance. Put another way, there's very little long-term difference in the performance of individual directors, whereas there's lots of variation in the performance of hospitals long-term. But if you do the same thing for pay, if you look at columns 2, 3, and 4, there is significant variation across directors in pay. So the market thinks some directors are better than others in that these are market set wages within bounds. So the results are the director effects explain very little of the variation in long-term performance of these hospitals. There's very little evidence, which I haven't shown you, that you can take performance in one hospital the next time to the hospital you move to next. But director effects in pay are important and they are portable. So if an individual's well paid in hospital A moves to hospital B, they're also well paid relative to the other directors and the level of pay in those hospitals in that hospital. So why might this be? First of all, is it short tenure? So we can't establish anything causal, but we actually find out, I've told you already that the tenure is short. So we're going to look at the relationship between tenure and performance, and we actually find that individuals who, so that's one of the things we're going to look at. And the second thing is you might think that a manager who performs well in one hospital actually then is hired by a hospital that actually is doing rather badly. So actually having any kind of long-term effect on performance is kind of hard because you did well in one hospital, but then you go to somewhere where it's very difficult to do something. So we're going to look at that as well as an explanation. And actually we find that there's no evidence that good managers are subsequently hired in hospitals that are not performing well. So that doesn't explain it. And we also find that but we do find that those individuals who are in post longer appear to have better hospital performance. So there's some suggestion that the tenures are too short. We then look at whether people have got pay for performance. The idea behind letting boards set their own pay was that the reforms gave boards pay-setting responsibilities and were to attract better managers, you could pay higher salaries. As I said, the salary differences weren't huge, but relative to other salaries in the public sector, NHS hospital managers were paid the most, more than, for example, running a large local authority, which is also a difficult activity. So the fact that we find directors' limited impact on production but persistent pay differences across these directors raises questions about the effectiveness of this model of allowing hospitals to have their own remuneration boards and set their own salaries. But we then ask, well, are pay and performance linked? So we look at that in a number of ways. We look at the relationship between the individual's pay over the whole time we see them and their performance over the whole time we see them. We look at the relationship between the pay in a particular hospital and their performance in a particular hospital. And then we look to see what happens to a director's pay when they move hospitals. So the kind of bottom line of that is that we find no relationship between pay and production, either over the whole lifetime of the director as we observed them in the data, or in one hospital. So if I perform well in a hospital, it doesn't mean that I have a higher than average pay. What we do find, though, is that on moving hospitals, directors' pay jumps about £4,000, which is about 3% of their kind of base salary, a little bit more. So clearly on moving, people get paid more. And they get paid more for going to certain hospitals. If they move to a more prestigious hospital, they get a bigger pay jump. Well, that sort of makes sense. But also, in periods when there's less competition for managerial talent, because mergers are happening in this sector, because of that, during that period, we find that they get paid less. So there's clearly some competition going on in the market with bigger and more prestigious hospitals being able to pay more, and hospitals, when there's a very competitive environment for hospitals are in a competitive position, they can pay less. So our conclusions are, we find very little evidence of top director influence on what those hospitals do. And I showed you a number of key targets. We find this across a range of inputs and throughput measures. This is not due to endogenous sorting, people being sent to the salt mines or after they've performed well. There's suggestive evidence that actually what's happening here is this market moves too much. These folk are moving too much between hospitals to have an impact, though that's not causal. And we find that differences in pay, which exist, some managers are clearly seen by the market as better, is generally uncorrelated with performance. So why might this be? And I think there's a number of explanations, none of which we kind of take. So I think there's a number. One is there simply may be lack of managerial talent, that this pool of directors of NHS hospitals simply don't have enough talent to be managing these very difficult organisations, or at least the pool is such that everyone's pretty homogeneous. Secondly, the supply of managers might be adequate, but the reforms could not overcome the political pressures from government. The fact that government would move from one target to another meant that actually directing your hospital on one course meant that, 6 months later, some other target was set. And there was definitely a lot of political control. Thirdly, the managers, they're too short. Their short-term managers can't manage large, complex organizations, in which the other point is these managers are short-term, but the doctors and nurses that are there for life. So basically, you've got a kind of managerial problem where everybody knows the directors may only be there for 4 years. You're a medical professional, you can be there for life. You may have little kind of incentive to actually do what the latest idea from the top is. And I think what this says probably is that instead of focusing on kind of improving the board, what you possibly should do is try and improve managerial competence at lower levels where people stay longer or can move between jobs within a hospital. And some work that Nick Bloom, John Van Reenen, and Stefan Seiler and I did some time ago showed that managerial training was associated, or managerial practices was associated with better performance in NHS hospitals. And I think finally, regardless of what you think's driving this does raise concerns about governments mimicking the arrangements for private sector organizations for large, complex organizations. It clearly might work for social security offices, and possibly does work in some schools and not others. But schools and social security offices and sort of the DVLA and other sort of agencies are a very different beast to these large, complex organizations which essentially employ professionals for life and managers come and go. And so there's a very nice quote by some academics who specialize in this sector and in kind of qualitative research, which says much of the senior managerial people seem genuine and intelligent, who initially give the impression that they're going to overcome all the long-standing problems that the hospital has. A year or so later, it becomes kind of completely apparent that they can do nothing. And this medical director suggested, the head of a clinical director who has a job for life, suggested that the central NHS organisation, i.e. the regulatory control by the Department of Health, left very little room for managerial manoeuvre in this kind of situation. And that they essentially ended up simply, instead of running their hospitals, essentially managing the bureaucracy from central government to focus on a number of things that the bureaucracy wanted, rather than perhaps they decided as an autonomous board. So at that point, I want to thank you, and happy to take any questions.
Okay, thank you very much, Carol. You did perfectly in terms of timing. So now we have an opportunity for questions. So anyone want to start off? That's a very interesting paper. Russ, yes. A microphone is coming to you. Thank you.
Very interesting results. I wonder, since we're talking about the frontiers of competition, if you looked into whether that big fixed effect, I'll call it, for the hospital itself might be affected by competition from other hospitals. In particular, for example, the distance to the nearest other hospital that does the same thing.
Yeah, that's a really good point. And actually, that's something we haven't looked at, even though I've done lots of work on competition between hospitals. So thank you for that suggestion. It's kind of a no-brainer, isn't it? But we haven't looked at it. We have this has been a very long gestation, this paper, for various reasons. We have at some time looked to see whether these are, for example, the best performing hospitals are the big London hospitals, who obviously have more competition around them, partly because the big London hospitals, which people don't actually always know, are actually smaller than some of the hospitals in other areas, because they're just lots of them, relatively. And we didn't find that good performance was necessarily associated long-term with the big London hospitals, and that makes sense. There are some that have done better than others. But we haven't actually looked in detail to your question, which I think is an excellent question. Thank you for that.
Hi, thank you. I just had a question about the two-way fixed effects model. I'm assuming in the same way that you put the medical director data to feed the model, there's a set of hospital effect data that was found to have a bigger impact. Would you be able to describe what those factors are? Because assumedly that could be quite important in understanding how to improve hospitals.
Yes, so we did look, other than competition, at correlates of those hospital fixed effects, which are important, and you'd expect them to be important, you know. So we looked at whether it was associated with age, we looked at whether it was associated with capital, we looked at whether it was associated with size. And in fact, the answer is no. There were some hospitals that just performed. So essentially, those hospital fixed effects, we do net out, obviously, time-varying effects in that, but the hospital fixed effects don't seem to be particularly correlated with obvious features like that. And that is one of the things we'd like to kind of look at a bit more. Our focus so far has obviously been on the performance of directors, leaving those fixed effects. But I think it kind of speaks also to Russell's question that essentially, what is it that drives those hospital fixed effects would be a nice thing to know. And our preliminary kind of, a long time ago work on it didn't show that there were significant patterns across age or across capital. One of the things that is associated with poorer performance is PFI, which those of you in the room, some of you know about, which is the Public Finance Initiative. Some hospitals, essentially, the only way you could borrow capital in this period, or in some of this period, well, in most of this period, was to go to the private market. Many hospitals signed really bad deals in that, I mean, you'd expect the private sector knows what it's doing. Hospital managers probably had no idea what they were getting into with some of the PFI contracts. And the PFI contracts are associated with poorer performance.
Just one last question, and then we'll close out.
Thank you so much. Franco Mariuzzo from CCP. So it's very much related to the previous question. So the hospitals, in a way, we can think about would be easier if there were perhaps pediatric ward, all of them. Then we can make comparisons into that. But they are complicated because some of them are specialized, others are not. And the specialization does change over time through, if you want, concentrations, to changing, you buy, you start expanding, contracting. So is it possible to have at least a measure of, if you want, specializations in a way? Because if you have molecular genetics in the hospital, the only one in the country, I do wonder, would it be pay more those managers or not? And versus if you're just providing the same service as anyone else. Some of your two-way fixed effect will not be able to capture that. But I do wonder, is any other way to control for that? This is very much related to competition in a way, but specialization is one important aspect that perhaps might play a role, and it might change over time.
Sure. I mean, I didn't quite catch all of your question because the mics here are not great. But basically, you're asking, yes, clearly we control for time varying factors. And as you say, over a 14-year period, the regimes change. And hospitals might become more or less specialized. So there's always a question in this into what you stick in the controls in a two-way fixed effects model, the time varying controls, and what you think is endogenous. So we do control for things like in the final regressions that you see, we control for bed size, which varies. We control for specialist services. We actually control for capital, which is partly why we didn't then go and look at whether these things were associated, because in some ways we were controlling for them. So I think there's always a question about what you control for, but those we have a very large range of time varying factors, some of which we decided were just too endogenous, and some of which we decided were less endogenous. Obviously, things like being a specialist hospital is obvious, and anyway, that gets sucked up as a fixed effect because a children's hospital doesn't suddenly become something else. In fact, in Britain, there aren't that many specialist hospitals. There's a couple of hospitals for rheumatology, one hospital for neurology, and 3 or 4 specialist children's hospitals. Some cancer hospitals, but that's all controlled for, yes.
Great, then thank you very much, Carol. I'm going to have some other questions for you later, but I think we have to move on now. So thanks once again.
Thank you.
And now we will hand over at this point to Marty Gaynor, who is on the agenda as being at Carnegie Mellon University. This is perhaps a factual kind of question that we could talk about later, but he's just retiring or retired, and so anyway, we're going to say you're from Carnegie Mellon, and your bio is in the brochure as before. So you'll be talking about expecting harm, the impact of rural hospital acquisitions on access to maternal health services. So looking forward to it.
Thanks, Sean. Pleasure to be here. I'm a professor emeritus, so I still have a Carnegie Mellon affiliation. Before I begin, let me just make a quick disclosure. We do not receive any external funding for this work, nor do any of us have affiliations with any interested parties. I served at the Antitrust Division, U.S. Department of Justice, during part of the time the search was being conducted, but there were no investigations or other activities at the Antitrust Division that were in any way related to this. So I think that's pretty much full disclosure. This work is with my wonderful co-authors, David Dranov and Aileen Geddes. This is about what's happening in the U.S. hospital sector, so obviously there are institutional facts relevant to that. I will do my best to explain as we go along, but please feel free to ask questions if anything isn't clear. There's been a tremendous amount of consolidation in the U.S. hospital sector over the past 30 plus years, well over 1,600 mergers on a base of about 5,000, starting about 30 some odd years ago. So tremendous amount of consolidation. Well-documented effects on prices. So the vast majority of hospitals in the United States are privately owned and operated. Most of them are nonprofit firms, but they negotiate prices with private health insurance companies. So those prices are market determined. Hospital mergers tend to have very substantial effects on prices, increasing them, and also on quality. Pretty much no enhancements to quality due to merger and acquisition. One thing, however, that has not been studied much is what effects, if any, there are on access to care. Are people able to get care that they desire at hospitals, particularly for those among us who are least fortunate, low-income people, and others. So here we're going to focus in on something very specific. We're going to focus on obstetric care in rural markets in the U.S. And in a moment, I'll talk about why we've chosen to do that. But first, let's just talk a little bit about why mergers might affect access to care. So one thing, again, to think about here in the U.S. context is the following. There are roughly three major categories of health insurance in the United States. One is private health insurance. Mostly individuals who have that have those through their employer. So for another couple months, I have private health insurance sponsored by my employer, Carnegie Mellon University. That's the vast majority of the US population. Another group of people who are 65 and older, and people have certain kinds of disabilities, but mainly people are 65 and older. I used to say elderly, but now that I'm just a little bit over 65, I use the term 65 and older. Anyhow, those people have public health insurance through the federal government. That is called Medicare. Third group of people, roughly low-income people, and people have certain other kinds of disabilities, get public health insurance that is jointly financed by the federal and state governments, and that is called Medicaid. Okay, so now, if mergers lead to increases in prices for the private sector, what happens to access to care for people with public health insurance? It's a fact that prices paid by private health insurance companies to hospitals are the highest. After that are prices paid by Medicare, which is public health insurance for 65 and older, and lowest are prices paid by Medicaid, which is public health insurance for low-income people. Well, if you can negotiate higher prices on the privately insured, and if your costs haven't gone up or haven't gone up much, if your profits go up, then you just as soon see more of those people, right? That's more profitable. And if you have capacity costs or fixed capacity, then you very well might want to see fewer of the less profitable patients, the people with public health insurance. Now, there's a lot more to this than that, but that's the basic idea. So a very simple idea. And that could be another harm for enhanced market power. So one thing that might happen is merger allows these hospitals to raise prices on the private side. On the public side, they're far less interested in seeing patients who have public health insurance. They have less access to care. That can be another harm from enhanced market power due to due to merger. There are also possible efficiencies. Hospitals might consolidate care, they might integrate care, those could reduce costs, those could increase quality. Actually, there's quite a bit of evidence on that as well, and evidence on average that doesn't happen. It does happen in some cases, but it's not systematically true that hospital mergers in the United States lead to any cognizable, any deficiencies of any kind. Even if that were the case, nonetheless, the impact can be to reduce, if it reduces local access, that's something that works the other way. There may be some efficiencies if efficiencies are gained system-wide, but it could cause harm at the local level. It's also possible that hospitals, as I said, most of these hospitals are private, but they are nonprofit firms. They might pursue community benefit objectives because they're nonprofit. And even if they increase profits due to merger, they might spend those profits on things that benefit the community, sort of a Robin Hood effect. It turns out there's no evidence that they do that at all, but that is certainly something that, at least theoretically, is a possibility. Now, why obstetrics care and in rural areas? Well, the questions around access to care are particularly salient. It wouldn't be surprising, like, well, obstetric care, access to an obstetrics unit at a hospital is very important. The overwhelming majority of babies in the United States are born in hospitals. There are very few born in locations outside of hospitals, birthing centers, or at home. That's quite unusual. Now, there have been a lot of closures of hospital obstetric units. Over 400 counties had the only hospital obstetrics units close over the past 30 years. Now, only 1/2 of counties in the entire country have a hospital with an obstetrics unit. So there are a lot of concerns about this. So if there are women who are pregnant living in a county with no obstetrics units, obviously they're going to have to travel farther for care. That includes not just labor and delivery, but prenatal care as well. It might reduce the quantity or quality of care before, during, or after delivery. It might harm continuity of care, coordination, integration of care. Now, in rural areas, there have been a lot of hospital closures, a lot of acquisitions of hospitals. It's hard for hospitals in these rural areas to be profitable. Back in 2019, 70%, well over 2/3 of non-rural hospitals had positive profit margins versus 62%, well under 2/3 of rural hospitals. More than 200 hospitals in rural areas just stopped delivering babies entirely over the past 10 years, and half of rural hospitals no longer have labor and delivery services at all. So there's a lot of concern about this and concern about the fate of hospitals in rural areas more generally. And what did we do? We take an event study approach to look at the effects of being acquired, a hospital in rural area being acquired, on obstetric care in rural areas. Preview of findings for anyone who's impatient. This is the paper while standing on one foot. Acquired hospitals are more likely to close obstetric units following acquisition. They see fewer Medicaid patients. These are patients with public health insurance, lower income patients. They have fewer nurses on staff. That could be potential cost savings, but it could also compromise the quality of care. In counties where hospitals were acquired, rural counties where hospitals were acquired, there are declines in the number of obstetricians per capita. So there are fewer physicians located in those counties who are specialized in obstetrics and gynecology. Increase in the distance that patients travel for labor and delivery. We say no large changes in infant outcomes on average. There are some small increases in some interventions during labor and delivery. Yeah, yes, sir.
Why do we accept Medicare patients in the beginning? Why do they wait for the merger to shut it down?
Why do they even see these patients in the first place?
Yeah, like why would the merger affect?
Yossi, can you take the? Yeah.
If
Yeah,
these
the-
patients are not, if these patients are not profitable, then why wait for the merger to shut down the
Right.
unit?
Yeah. Well, so I'm not saying, what I was saying initially is if post-merger, there's a price increase on the private side, right, there might be less interest in seeing public patients because the gap in profitability has increased. So that's saying, supposing before merger, right, you were seeing a mix of public and private patients. Post-merger, you might be less interested because of the increase in price. Now, the phenomenon here, there are a bunch of things going on. One thing you'll see is we're not actually documenting what happens to prices here. There are also changes in management, and the changes in management may have a lot to do with this. Now, we're taking, and you'll see this in a moment, an event study, difference in difference approach to this, which documents what happens, but is, as well known about these kinds of approaches, black box. It doesn't tell you exactly why this is happening. We can come back and discuss this further later. Thanks. Good question. Now, data, we have a number of different data sources. The American Hospital Association, National Trade Association for Hospitals, does an annual survey of hospitals. They collect information on hospital ownership, service line staffing, et cetera. We have access to those data. The data on ownership are not perfect. There are some issues with those, particularly regarding merger and acquisition. So we have a private data set collected by an outfit called Irving Levin and Associates that documents mergers and acquisitions, changes in ownership. We use that to validate and correct merger data from the American Hospital Association data. We have 467 total mergers in our time period, 2006 to 2019, involving rural hospitals. 270 of these were the first time the hospital was acquired during the sample period, and that's what we want. We don't want a hospital to have been acquired multiple times during the sample period because it makes identification of the acquisition effect more difficult. So we're going to focus on that with 270 of those. And we also have data from the US Medicare program, something called the Healthcare Cost Report Information System that has financial information on hospitals. We also have data at the county level, National Vital Statistics System birth records for the entire country, outcomes for every single birth in the United States. The American Community Survey, which is done by the US Census, collects socio-demographic information, area health resource files, and information on healthcare practitioners. Like I just mentioned, number of obstetrician gynecologists in a county. We're going to do hospital and county level analysis. I mentioned we do difference in differences here, and you can see the first equation here, standard approach. We have fixed effects for the hospital and the year. We've got a post-merger effect, and we have an event study approach where we, over the entire time period, we look at the effects. So very, very similar, but one just has a single post-merger effect. The other, we look over the entire time period. And county level unit of analysis, but the difference in difference econometric specification and the event study are the same. It's just a different level of analysis. Now, it has to be the case that acquired hospitals would have, but for the merger, evolved similarly to non-acquired hospitals in the absence of the merger. Otherwise, if that's not the case, then we don't have such a clean evaluation here. So to get a sense of that, we look at treated and untreated hospitals, those that were acquired, those that were not. We look at pre-trends. We look for evidence of population changes in counties. Were hospitals acquired, did they look different in terms of what's happening to population, per capita income, or that kind of thing? And here's a look at a comparison between acquired and never acquired hospitals. You can see that for the most part, there's no significant difference on a whole bunch of different characteristics. Of course, you can't read that type on there. I can't read it myself either. But but you can see that that for the most part, there's no difference. The acquired hospitals are somewhat larger than those that were not acquired. We also separately look at what happened to population, number of births, number of deaths, income, percent of the population with no health insurance at all, whether those were changing. The trends on those are different in counties where the hospitals acquired not, and we don't find any difference in that. So these are at least reassuring with regard to key assumptions. Now, results. The effect of an acquisition is that acquired hospitals are substantially more likely to close their obstetrics units. So about a 17% decline in the probability of having an OB unit if you are acquired. We don't find any evidence of differential pre-trends between those hospitals that were acquired and those that were not. We fiddle around with a bunch of different control groups with inverse probability weighting, and none of that really changes any of this. So this is quite a robust result. If your hospital gets acquired, chances are pretty good that it's going to close the obstetrics unit. Now, not surprisingly, associated with that, well, you see a decline in births, right? And you also see a decline in the number of Medicaid discharges, the number of patients who have Medicaid public health insurance who are treated at that hospital. So for I think the largest number of claims that Medicaid gets is for labor and delivery. The Medicaid population tends to be younger, and a lot of people on Medicaid are women who are younger and, not surprisingly, given their age group, are having babies. So we find declines in those. 28% reduction in the number of births and 20% reduction in Medicaid discharges. There are also declines at the county level in healthcare resources. We see a decrease in the number of obstetric beds in hospitals. I've got 5 minutes. Okay.
No, you have a bit more.
Okay.
You have to be done by 10:35. So if you could be done at 10:30, that would.
No worries. Yeah. Okay. And the distance people travel for obstetric care increases, and the number of obstetrician gynecologists per capita also goes down. None of this is terribly surprising. If you think about it for a moment, if there's only a single hospital in a county, that hospital closes obstetrics units. Any OBGYNs who are practicing in that area are probably going to go elsewhere. But one thing to bear in mind too is that this then has an impact not just on care in the hospital, but care before the hospital. Prenatal care, typically delivered by obstetrician gynecologists before the hospital, and there are a few of those in the county. That's going to have impact on prenatal care as well as labor and delivery, and as well as postnatal care.
Can we get a mic to Kyovik, please?
Yeah.
Well, sorry, I think this goes back to Yossi's question. If you can go back to the previous slide, you're essentially saying you get a capacity reduction overall, and at the margin, a reduction in the beds of those beds that have the least margin on them. Is it possible that very often, I mean, we see this in a lot of industries, that cost cutting is only done after a merger, and you're kind of changing the administrative structures and have someone who actually is put in order to do cost reduction? And that's completely consistent also with your comparison with the other hospitals. It's going to be a hospital at the margin that's going to be affected, and not the inframarginal hospitals. So you're not going to see differences in the trends there. But is this just kind of that very typically structural change that's needed comes through mergers?
Yeah, I'm sorry. Could you repeat the last bit of the question?
So the question really to me is whether this is not just simply evidence that shows, as in many industries, structural change through cost cutting comes through mergers, and is not usually achieved through firms kind of continuing in same ownership.
Yeah, well, so these changes are, so one thing, again, we look at pre-trends, right? We don't find this difference in pre-trends for acquired and not acquired. So it doesn't seem to be that.
That's what I'm taking issue with.
I'm sorry?
That interpretation is what I'm taking issue with. You're kind of, if all the efficiency, if the capacity reduction that's needed is going to come in just through the marginal hospital, then you're not going to see differences in pre-trend. You're just basically seeing that someone going to come in and is going to take capacity out of the market in order to make things more profitable. It's going to make it more profitable for everyone, yes, but.
Yeah, yeah. Well, yeah, let's hold out, maybe come back to that later. All right, so patients post-acquisition go outside the county for labor and delivery, so they're traveling farther. In terms of actual treatments, we don't find there are changes in the C-section or induction rate. So it's not like post-acquisition, women are much more likely to get cesarean sections or have labor induced. So we don't see that in terms of the way people are being treated. We do see some changes in terms of other kinds of treatment, labor augmentation and the use of anesthesia. We do see some decreases in transfers. So there's some changes in the way these patients are treated, but not wholesale changes across the board. We do not see evidence of impacts on infants. So LBW is low birth weight. That is something that is problematic, not so much in and of itself, but it's very, very strongly associated with health problems. For newborns, we don't see impacts on low birth weight or whether a baby's preterm. Similar, that's a problem. On APGAR score, that's a measure of how well a newborn is functioning or on the presence of abnormalities. The APGAR 5 score, that's marginally significant, but it's a very, very small number, the point estimate itself. We don't find any impacts on infant or maternal mortality. So now we have a 2006 to 2019 time period. So we're permitting, or there's a fairly long time period here, at least for the acquisitions that happened early in the time period, long time period during which these things could show up. And we're not finding evidence of impacts on that. So again, one of the concerns is that an acquisition happens, obstetrics unit gets closed, people have to go elsewhere. That sounds like it really could be bad. It could have a really negative impact on the health of mothers, the health of infants. And we're not finding anything, at least, that is serious enough to move things in terms of mortality. It doesn't mean there couldn't be other things happening, but that is not showing up at all. So wrapping up, we don't find any evidence of impacts on health and outcomes for moms or babies. There are negative impacts of closures, and one of those, of course, is that there's a decrease in patient choice, right? There is a place that people had in their choice set that now has been taken out. And any standard model will say that's going to decrease patient welfare, certainly with perfect information. There is an increase in distance traveled, so that also is a negative impact for patients. There are spillovers availability of other healthcare services, some impacts on labor and delivery treatment. I didn't have this in the slides because these are relatively recent results, but there's some impacts on prenatal care. We see evidence of higher smoking rates by pregnant women post-acquisition, and an increase in the rate of gestational diabetes. But again, no detectable impacts on health outcomes for infants or moms during our study period. So some impacts, but certainly not dramatic. It does not jump out. There may be some positive impacts of closures. Patients may go to higher quality hospitals. Again, I don't have this in the slides, but something we looked at recently is what happens when a hospital is acquired, but the OB unit is kept open. And we do see actually some improvements in treatments and outcomes for those kinds of cases. It's also possible, of course, these acquisitions might reduce costs. There are some evidence, not a lot, not great evidence, some evidence, there are scale economies in both labor and capital. So overall, it's not so obvious that these mergers that induce closures of these obstetric units harm patients. This is contrary to expectations. There was a great deal of concern about closures of rural hospitals in the United States. Every politician talks about this. Every state has, of course, rural areas in it. There's always concern expressed about this. And intuitively, it's obvious why we would be concerned. And obstetrics seems like an area that, that you might see this. You expect to see very vulnerable patients here. But we're not finding it here. Now, again, as I said earlier, we take an event study, difference in difference approach. It is black box. It's not an econometric approach that is suited to identifying causal mechanisms. You can see what happened, but you can't really say exactly what's driving that. So there are a number of things that are possible. Maybe these are hospitals that were just not doing so great for a period of time already. And so women who had more serious problems were going elsewhere for even prior to the acquisition. So we're just not seeing a big effect. One thing that could be done in terms of more research in this area, which we have not done here, is to specify and estimate a structural model of this phenomenon. Now, I don't think that's the first step. The first step is to do what we did, which is the most straightforward thing to do, and see, does there seem to be something going on here? But if you want to get at sort of exactly what's driving this and identify causal mechanisms, then I think you would have to look at this in more detail. Anyhow, that's really all I have to say. We thought it was important to take a look at this aspect of merger impacts. It really has not been studied very much. And at least I thought, I can't speak for my co-authors, I thought we would likely find some non-trivial negative impacts on patients, and we haven't been finding them, which at least actually is somewhat reassuring. Maybe these things are working better than one might have thought. Thank you.
Okay. Thank you, Marty. And now open back up to questions. We have a question from. Can you identify yourself for the audience online, please?
So my name is Yossi. I'm from Tel Aviv. My question is this. Your result reminds me of this paper by Eliasson et al. They look at acquisitions of dialysis centers in the US. It was published in the QJE 2020. And what they find is that once a local dialysis center is acquired by one of these large chains, they start to inject a lot of EPOs into their patients because they are get paid by Medicare for the EPOs. And obviously, they don't send patients to kidney transplants anymore. The total reduction in quality, et cetera, et cetera, et cetera. And one interpretation that they have is that if you are a local dialysis center, you kind of live in the community, you know the patients, maybe you send your kids to the same school with the patients, and you don't see the patients as money-making machines. You don't inject EPOs into your neighbors. But once this is acquired by a large center that is managed somewhere else, they don't care. They view it as a way to make money. So I was wondering whether it's the same thing here. Like if you are a local hospital, you are in a rural area, you live in the community, you feel some responsibility for the community, and you provide for Medicare patients. Once you are acquired by someone else, he sits somewhere else, doesn't care, and therefore he sees this as a losing proposition, and he cuts the OB centers. So I was wondering whether it makes any sense.
Yeah, I'm familiar with that paper. It's a really, really interesting paper. That certainly could be. I mean, this is something we've discussed a great deal. New management sees fit to change things, right? Why didn't the original management do that? Why is it that has changed now?
Right. So the idea is that if you live in the community, you feel responsibility. Once you manage the stuff from miles away, you don't know the people, you don't care.
Right. Well, typically these hospitals are managed or overseen by a governing board composed of people from the local community. When the acquisition happens, even if it's another nonprofit, the governing board is from somewhere else. They don't feel the same connection or perhaps sense of obligation to the community, so they're willing to take steps, measures that the prior management wouldn't. Now, we don't know that for a fact. That's just hypothesis. So we do see this happening. Again, the thing I think I was a bit surprised about is I thought we would detect bigger impacts on patients than we seem to detect.
Okay, we have a question over here. I think this will be our last question. And I should just note for the record that all the conference is being recorded, so please keep that in mind as we speak today.
Yes, I'll be mindful of that. Thank you for inviting me, Sean. I have the honor to be an alumnus of the certificate course, and I've been offered a free place, so that's my disclosure here. As probably the only licensed practitioner of medicine in this room, I've not only had the pleasure of looking after babies, but also delivering them. So I may have a few things to add. With regard to what patients you can accept in an obstetrics department, you have EMTALA. You cannot refuse emergency admissions as per federal law. So you cannot just say you don't, you're going to be very selective in admitting patients. With regard to profitability of OBGYN units, this is a specialty that's highly prone to malpractice suits. So that is also a consideration for hospital managers. With regard to reducing certain services, if you reduce services, you also impact on the overall prestige of a service. If your hospital system will have the additional benefit of being a comprehensive provider of services as opposed to a patchwork of departments. With regard to Yassi's comment about EPOs, I don't know if everyone knows about what EPOs are. This is erythropoietin, which is given to patients with renal transplant. So this is a way of reducing the need for blood transfusions. For those who are wondering, it's a bit like, yes, it is a, you can bill for providing injections of EPO, erythropoietin. So thank you very much for bringing this paper, and I appreciate. I did a MPH, Masters in Public Health, some 9 years ago at the University of Florida, and I realized that not much has changed since with regard to the healthcare system. Thank you very much.
Okay, thank you. I think, I'm not sure there's a question, but I think we need to close out in any case. So thank you for the comment. And we will now move over to the next part of the agenda. So once again, thanks, thanks, Marty.
So this may sound like it's coming in the reverse order, but my job is to introduce our keynote speaker. It's my great pleasure and honor to introduce our keynote speaker, Professor Marty Gaynor. Marty is one of the world's leading experts on competition policy and healthcare markets. He is the Lester A. Hamburg University Professor of Economics and Public Policy, Emeritus at Carnegie Mellon University, where he has been on the faculty since 1995. He is also an International Research Fellow at the University of Bristol. Over the course of his remarkable career, Marty has produced an extraordinary body of research that has shaped both academic thinking and real-world policy. His work has directly influenced antitrust enforcement and health policy in the United States, and through his services as Director of the Bureau of Economics at the Federal Trade Commission, and most recently as Special Advisor to the Assistant Attorney General at the Department of Justice Antitrust Division. Marty has received numerous awards over his career, including most recently the prestigious Victor R. Fuchs Award for lifetime contributions to health economics, as well as other notable honors, including the Kenneth J. Arrow Awards for research in health economics, and is an elected member of both the National Academy of Medicine and National Academy of Social Insurance, reflecting his wide-ranging impact on policy and scholarship. Marty's scholarship, covering everything from hospital consolidation and insurer markets to provider incentives and now digital health platforms, has not only deepened our understanding of how healthcare markets function, but also how to make them work better. While much of his work has influenced US policy, his research extends well beyond, with studies on systems like the NHS in the UK and broader relevance to healthcare markets around the world. He has published in top economic journals, testified before Congress and federal agencies, and advised governments globally, including the UK, the Netherlands, and South Africa, proving no country is safe from PowerPoint presentations on market concentration. But beyond all this, I want to say something more personal. Marty was my PhD advisor at Carnegie Mellon, and I'm just one of the 30 doctoral students, over 30 doctoral students he has mentored over his career, many of whom have gone on to successful careers in academia, government, and the private sector. His intellectual generosity, patient mentorship, and unwavering support has made a lasting impression and lasting impact on generations of economists. Marty doesn't just train students. He builds thinkers, scholars, and leaders. Of course, there are exceptions. I'm living proof that even a great mentor can only do so much. Today, Marty will address a topic of great importance to many in this room, the role of economics in antitrust cases. Given his profound academic contributions, his direct experience at the highest levels at the US antitrust enforcement, and ongoing engagement with emerging competition challenges, I can think of no one better suited to help us think through this process. Please join me in welcoming Marty again.
Let's see, oh, you get to see all my additional slides. Oh, there we go. Thank you so much, Farasat. It's a real pleasure to be here. It's very special to be here with you. Done well. Morning. Thank you for inviting me, giving me the opportunity to address such a distinguished gathering. Before I begin, let me disclose funding sources and possible sources of influence on this talk. I have received no funding for this or for work on any related topics, nor have I served as a consultant to any entities with an interest in competition enforcement or policy, or as a consultant to any entity on any topic for quite a few years now. I served with the Antitrust Division of the U.S. Department of Justice, as Farasat said, from October 2023 to November 2024. I did not work on the topics I cover on this talk, nor write on them while I was there, although my experiences at the Antitrust Division undoubtedly influenced my thinking. Now, let me begin. The role of economics in competition enforcement and policy has been the subject of some controversy, and I suggest some misunderstanding in recent years. Some have alleged that economics and economists play too large a role in competition enforcement, or even have a malevolent or malicious influence. Correspondingly, there have been suggestions that economics should play a much smaller and far more limited role in competition enforcement and policy. I think this would be a serious mistake. Economics is an essential part of competition enforcement and policy. If anything, we should have more of it. However, it can be used more effectively. In what follows, I'll develop and discuss these 2 points. First, at a high level, market functioning is fundamentally a matter of economics. The analysis and understanding of markets and how they work is central to economics. Economists have the analytical framework, methodological tools, and expertise to bring to bear on the key problems that confront competition enforcement and policy. What I'm describing here is positive analysis, understanding what is. Normative analysis, what should be, is related but separate. Economics is also central here in evaluating performance and how it compares to the desired objective. However, economics is not dispositive about what should be the objectives of competition enforcement and policy. Economics has well-defined metrics that can serve as normative objectives: consumer welfare or social welfare. Consumer welfare is simply a measure of how well off consumers are from market outcomes. Of course, this standard applies in a straightforward way to input, for example, labor markets, as well as output or product markets. Social welfare, which Robert Bork incorrectly or misleadingly labeled consumer welfare, is a simple sum of consumer welfare and producer welfare. Consumer welfare, and again, by this I mean the standard economics meaning of consumer welfare, not the Borkian use of the term, has been the objective pursued by competition enforcement and policy for many years now. However, this standard has been criticized in recent years, with several alternatives proposed. I'm not going to get involved in a discussion of different standards or different alternatives that have been proposed and discussed, but I am going to point out the following 3 things. First, economic analysis can accommodate virtually any objective. We can evaluate the performance of markets relative to whatever are society's stated goals. Economics is essential for this. As an analog, we do not discard the use of physics when we change the objectives of space exploration. Economic analysis can identify the impacts, both positive and negative, of various standards, as well as identify winners and losers. For example, if we decide to move from a consumer welfare standard to a citizen welfare standard, or a trading partner welfare standard, or a competitive process standard, or one that incorporates global competitiveness or environmental impacts, et cetera, economists can assess the impacts of moving from one standard to another, including the distributional impacts, who gains and who loses. I have yet to see any suggestions or discussion about different standards for competition enforcement do so much as even mention these, let alone make any effort to think about the impacts of changing standards. I strongly suggest that we think hard about this going forward as a way to inform and discipline our thinking. Second, economics is neither friend nor foe to plaintiffs or defendants. Neither is it supportive nor obstructive to more aggressive or less aggressive enforcement. As the famous British economist John Maynard Keynes said, the theory of economics does not furnish a body of settled conclusions immediately applicable to policy. Economics is a method rather than a doctrine, an apparatus of the mind, a technique of thinking which helps its possessor to draw correct conclusions. In other words, economics is a way of thinking about situations without presupposing or favoring any particular conclusions. Furthermore, the rigorous application of economics can identify the reasons that different analyses come to different conclusions, so that once identified, those factors can be subjected to critical evaluation. Third, I think we need to think critically and be quite hard-headed, but not hard-hearted, about what we ask of competition enforcement. Enforcement is a blunt tool, and quite frankly, one that is already challenging to implement successfully. There are many important social objectives, but we need to think about what competition enforcement is best suited to achieve and whether adding additional objectives may have the unintended effect of diminishing the effectiveness of enforcement. Now, this is really just a specific instance of the general point I made a moment ago about thinking clearly about impacts and trade-offs of moving to different standards for competition enforcement. In addition, this should fit within the goals and framework of competition policy writ large and of overall economic policy. Competition enforcement is really only a part, although of course a crucial part, of what I'll call competition policy. By competition policy, I mean the collection or constellation, I kind of like the term constellation, that sounds pretty elegant, of government policy, government actions that affect the functioning of markets in the economy. These are comprised of various laws and regulations, payment policies, monitoring, oversight, and enforcement, of which competition enforcement is a part. In addition, competition policy is part of any nation's overall economic policy. The key thing here is that the various elements of competition policy need to work together rather than at cross purposes, as does competition policy as an element of economic policy. For example, policies regarding allocation of gates to airlines, access to docking facilities at ports, payments to hospitals and physicians, et cetera, are the province of various government departments and all affect market structure and competition. There needs to be effective communication and coordination between these agencies and competition authorities. An example of this is the whole of government approach to competition by the Biden administration in the United States. There are other examples, I'm just citing that one. Similarly, competition policy should harmonize with overall economic policy. For example, initiatives in industrial policy or trade policy, innovation policy, and so on, that requires communication and coordination between competition authorities and other relevant agencies and those designing and implementing overall economic policy. While we've seen a welcome emphasis in recent years on taking account of competition and policy more broadly, this is something we need much more of, and it necessarily includes a critical role for economics. It's impossible to analyze and understand the impacts of policies within and across multiple agencies and sectors without the use of economics. For example, if we as a society have decided we want to achieve certain goals regarding the economy, for example, inclusive growth, shared prosperity, the abundant society, various terms that we hear nowadays, we need to design and implement a coherent, cohesive economic policy to achieve those goals, and we must have an intellectual framework with which to analyze and design such policies. Economics is clearly a central part of this. This is an area where economics can be used more effectively, and frankly, not just more effectively, more and better. Let me now move to two specific issues with how to use economics effectively that have been the subject of some debate and controversy within competition enforcement. By the way, by focusing on some issues with economics, I'm not implying there aren't issues with how legal analysis is used in competition enforcement policy. There are plenty of those issues as well. However, those are beyond the scope of this talk today, and I leave it to my colleagues with legal expertise to discuss them. The first issue has to do with the role of economic models in modeling. The second has to do with the role of economics experts. In both cases, we're making use of economics and economists as is appropriate. The issue is whether this is being done effectively, and if not, what we might need to do about it. Let me first discuss economic modeling. Some have decried the role of economic modeling in competition enforcement with the concern that economic models obfuscate rather than illuminate, and in some cases are perhaps deliberately used for this purpose. And moreover, the complicated modeling by economics experts is extremely expensive and strains the budget of enforcement agencies. I'll hold the second issue for now and include it as part of my discussion, the role of economics experts. Models are simply ways of organizing our thinking about the world. They are essential, and everyone uses them. Economics provides a structured, disciplined way of organizing our thinking, particularly about markets and how they function, and gives us the ability to select and organize facts. We absolutely need this kind of thinking. There should be no debate about that. There's no issue with the use of economic models. We need them. There are, however, in some cases, issues with how economic modeling is done and used. Models for the purpose of competition enforcement policy need to accurately reflect the realities of the markets in question, and a model should be as simple as possible to capture the key elements of interest, but no simpler. As Albert Einstein said, it can scarcely be denied that the supreme goal of all theory is to make the irreducible basic elements as simple and few as possible without having to surrender the adequate representation of a single datum of experience. A model can be mathematical or entirely verbal. Mathematics is simply a way to capture essential elements and subject one's thinking to rigorous examination. However, it's not the only way. A useful, rigorous model can be entirely verbal. The key thing is to provide a rigorous, pragmatic approach to thinking about the phenomenon at hand. This seems not only uncontroversial, but very useful. Indeed, economic models are employed all the time in a very practical, useful way. So how can, or does it, go wrong? There are a few ways. One is where the model doesn't reflect market realities. For example, if we rely on established ways of thinking, taking something off the shelf, as it were, rather than learning and understanding market realities and framing our thinking around them, so the model fits the market rather than trying to do it the other way around, that is not going to work well. Quoting John Maynard Keynes again, the difficulty lies not in the new ideas, but in escaping from the old ones, which ramify, for those brought up, as most as have been, into every corner of our minds. It's easy to fall into the pattern of thinking about new phenomena with existing frameworks. This can be particularly true when nested within an enforcement framework that incorporates litigation considerations. New approaches can be risky and may be perceived as harder to win with in court. They also take time and effort to develop, which is very costly to competition authorities faced with pressing problems to be addressed now. Models that don't reflect key market realities, however, run the risk of being exposed as such, and in any event, don't help address the important issues at hand. Following the familiar frequently works just fine, or better than fine, really well. But we have to critically assess that to make sure we don't miss the mark in certain situations and don't fall farther and farther behind when markets change and evolve. Another way it can go wrong is if the use of certain kinds of economic modeling makes it harder to get to the right outcome. More involved or more complicated isn't necessarily better. For example, complicated economic modeling, particularly dueling highly complicated models by opposing experts, can be difficult for courts to understand and can substantially raise the cost of litigation. We see this with some frequency with economic modeling for empirical evidence. Some might conclude that we should therefore discard economic analysis and instead turn to legal standards, such as, for example, rebuttable presumptions. Rebuttable presumptions can be much more straightforward for courts to assess and can circumscribe the analyses required to address them. However, even if we go this direction, economics has a critical role to play here as well. Careful economic analysis provides insights as when and how presumptions are appropriate. More broadly speaking, there can be a tension between accuracy and administrability. I'll try that 3 times fast. In enforcement and policy. It's important to acknowledge the existence of a trade-off and do one's best to assess it. Pretending that no trade-off exists is a recipe for avoidable mistakes. The core of economics is the assessment of trade-offs. So economics is yet again central to this appraisal. I do want to be clear that one should not rule out more involved or complicated or innovative economic modeling because of concerns about a court's ability to understand or because it may elicit even more involved or complicated economic modeling by the other side. One should use the analytic approach and methods that are best suited for the task at hand and not use less suitable approaches because they appear simpler. Recalling the quote from Einstein, he's not saying that a model has to be easy to comprehend. He's saying it must be as simple as possible to capture the phenomenon of interest. What he's talking about is parsimony in method, not necessarily making something simple for the sake of simplicity itself. So it's the task of the expert and the team they're working with to translate their analysis into terms that are comprehensible and useful to a court. This can be done and has been done successfully. We should not succumb to the tyranny of the status quo. Let me now turn to issues with economics experts. Here too, economics is critical. We need economics experts. However, we're not always using them as effectively as possible. While economic analysis and expertise are indispensable in competition enforcement, there are problems with what happens in practice. High stakes in enforcement matters, and the give and take and pushback between opposing experts leads to an incentive for experts and the parties who retain them to undertake extensive, highly detailed, and often complicated analyses. This can lead to analyses that cover both what's absolutely essential and what's less so, but for which an expert doesn't want to be caught unprepared by the other side. It can also result in situations where conflicts between experts' opinions turn on technical issues, which in some instances are buried deep in the analyses. Situations like this are hard for courts, staffed by generalist judges, to understand and evaluate, to the point where a confused judge throws up their hands and discards the evidence or only pays attention to the evidence they can understand, which on its own may lead to an incorrect decision. The arms race I've just described is a problem, although I don't think we have much information about how extensive this problem is, but qualitatively, I do think it is a problem, and private action is unlikely to solve it. There's an incentive for greater expenditure on expert analyses and more involved, expansive, and complicated analyses to the point where the heads of competition enforcement agencies have expressed serious concerns about the impacts on their budgets and their ability to pursue their agency's missions. The outcome is one in which both sides, defendants and plaintiffs, produce more expansive, complicated, and expensive analyses than is clearly necessary or optimal. It can also result in situations in which the side with deeper pockets outspends the other in an attempt to gain an advantage. There is also a problem with economics expert work that is baseless, unsupported, or misleading, perhaps deliberately so. Again, I don't think we have much information on how prevalent this is. There is an incentive for an expert to engage in this kind of work to the extent that it will increase the probability of desired outcome for the party which has retained them, and to the extent to which the expert benefits from that. There is, of course, the risk of baseless, unsupported, misleading work being exposed for what it is, but it may be beyond the ability of a court to distinguish between honest, competent work by an economics expert and that which is not. And it's far from evident that the market for experts works well enough to sufficiently discipline this kind of behavior. Last, there is a tension between an economist being asked for their opinions as an independent expert and being retained by an interested party. While there should be a hard distinction between expert and advocate, it's easy for that to be elided, and that can happen entirely subconsciously, and for the expert to slide into working for the party that has retained them. What to do? This is not a new issue, and it's been the subject of previous discussion about the problem and possible solutions. There are multiple possible approaches. I'm just going to suggest a couple here as a means of sparking thought and discussion. So I'm going to suggest a reform of the system that is intended to lead to economics experts fulfilling their appropriate role, that of a neutral expert as opposed to an advocate, and lead to appropriate and useful economic analyses. The reform is simple. Have an economic expert or experts retained by the court. One version of this is to have the court retain an economics expert in a role analogous to a special master, a court-appointed expert that directly advises the court. The court's expert will analyze the work and evidence produced by the party's experts and advise the court on the quality, relevance, and reliability of the work by the party's experts, as well as identify key issues and interpret or translate technical matters for the court. Depending on the circumstances, a court-appointed expert could also produce their own independent analyses for the court. The presence of a court-appointed expert can directly help the court in understanding the evidence produced by parties' experts, reduce confusion, and lead to better decisions. It can also have the indirect but very important effect of improving the work by parties' experts. Since experts retained by the parties know that their work will be reviewed by a fellow economist working for the court, they have a strong incentive to produce honest, high-quality work and to focus on the most important issues. Of course, it's critical that a court-appointed expert be high quality and unbiased. There could be an accreditation or certification process for experts to help address possible quality issues. It also might be appropriate for a court to retain more than one expert in order to avoid relying on a single viewpoint. A second possibility is for economics experts to be retained by the court instead of by the parties, and to produce analyses and report directly to the court. The court can set a budget for the experts, who then are either paid directly by the court or via levies the court imposes on the parties themselves, with no parties' funds allocated to any specific expert. A court-retained expert has no incentive to produce extraneous or misleading analysis. Their incentive is to produce evidence that will be most useful to the court. In the case where only the court hires experts, neither party has an advantage in terms of resources available to devote to experts, and spending on expert services may be contained. This possible reform is not perfect. Nothing is. In particular, courts may have an incentive to request analyses that are too simple or not relevant if they appear clearer or more understandable to a court. Courts may also have an incentive to spend too little, although having parties pay for experts might counteract this, or not have sufficient incentive or knowledge to hire the best experts. As I said a few moments ago, these are some initial ideas to get us thinking about a system that most effectively utilizes economics experts. There may be better or more practical ideas. I just hope these simple suggestions spark discussion and action that move us in the direction of finding and implementing changes to the system that maximize appropriate and useful work by economic experts. Last, I've been talking about the role of economics and competition enforcement and policy, but I want to be clear that, of course, law is also indispensable. We need competition law and the smart, dedicated, and hardworking lawyers we have to enforce those laws. Moreover, economics and law are complements. Economists and lawyers are essential to competition enforcement and policy, and we're partners working together to have markets perform to benefit society. Thank you.